Good morning, everyone. Thank you for joining. On behalf of our neurology department, I'd like to welcome you all to Grand Rounds. It's my honor to introduce our speaker today, Dr. Jose Gutierrez, who will be sharing his expertise on intracranial atherosclerotic disease, a topic of utmost clinical importance. Dr. Gutierrez is Florence Irving, Associate Professor of Neurology at Columbia University Medical Center in the city of New York. He obtained his medical degree from University of Guadalajara in Mexico and completed his neurology residency at the University of Miami. During residency, he also obtained a master's in public health with major in biostatistics from Florida International University. He then joined the Department of Neurology at Columbia, where he completed a 2-year fellowship in vascular neurology. Dr. Gutierrez is a clinical scientist, and his major interests include brain arterial remodeling in the context of atherosclerosis and aging, and how these changes may alter the risk of stroke and dementia in certain populations. Dr. Gutierrez's role as principal investigator has been supported consistently by grants from the AHA, the NIH, and the Campbell Foundation. He has published over 70 peer-reviewed articles, 12 book chapters, and over 30 poster and oral presentations at national and international meetings. Ultimately, his research goal is to find novel disease pathways that may be amenable to modifications, and with this, to palliate the social burden of cerebrovascular disease. It's our pleasure to have you here today, Dr. Gutierrez, and without further ado, I'd like to hand over the microphone to you.
Thank you, Srinath, for the generous introduction. Thank you for the invitation to talk about intracranial atherosclerosis and how that fits into the context of the incoming CAPTIVA trial that I'm going to take advantage of talking about briefly. Okay, so my disclosures are skipped, but mostly consistent of NIH grants. I don't have any commercial disclosure related to medications that I will talk about. I do have royalties from a chapter on intracranial stenosis and UpToDate and MedLink, and that's it. So starting with epidemiology, I think it's important to understand that traditionally people think that intracranial stenosis is more common in Asian countries and within Western countries such as the US, mostly in people of ethnic minorities, specifically Latino, Hispanic in the States, as well as African American. But it's important to look at the fine print of most papers, because the majority of assumptions come from hospital-based studies. There's really less data on a population scale, because until recently, ICAS or ICAT, and I'm going to use interchangeably, although I will emphasize the difference later, has been usually studied in the hospitals, and there used to be only very few true population-based studies that looked into this phenotype. But in general, here you see again that North America and Europe tend to be on the lower side of stroke-based or hospital-based registries in terms of prevalence or the impact of ICAS in stroke etiology. But if you look at the population-based studies, which is represented by the green, it's actually very similar, and I'll show you specific data. So let's say in the United States, we have 2 studies that have MRAs that are like true population-based studies. One of the most popular is Framingham Heart Study. They don't have MRAs, or at least did not until 2 years ago. So ERIC is a by ethnic cohort, usually or mostly comprising African Americans and whites in 4 different cities across the states. The Northern Manhattan study here in New York and in Northern Manhattan, as its name suggests, includes 66% Hispanic or Latino, mostly from Caribbean descent, and the other 40% is split between African American and non-Hispanic whites. The prevalence of any stenosis, so any luminal irregularity that people may think is abnormal, is 34% in ERIC and 40% in NOMA. So that is a lot. That means that of the population you see on the street in Northern Manhattan, 50 or older, 40% will have some degree of luminal stenosis. Now, if you do define stenosis like clinically significant at 50% or higher, that goes up to 8%, which is not negligible. That's significant, especially because of the risk that this phenotype carries. And in the Singapore cohort called EDIS, that I have the privilege to work with, their sample is split into people of Chinese descent, Malay descent, and Indian descent. And so in a single cohort, you have 3 different ethnicities. Granted, Singapore is a very wealthy country, and it may not be necessarily applicable to what other countries experience in Asia, but in Singapore, the prevalence of asymptomatic ICAS in the community was 8%, very similar to what NOMAS had. So just to show you again the numbers, that from a population perspective, the degree of stenosis is actually not that different between Asia and the United States, especially in certain populations. Now, who has more? Have we found any ethnic disparities in asymptomatic ICAS in Northern Manhattan? We have, but up to a certain point. In general, we couldn't find any significant difference, but if you stratify by age, you actually see that, I don't know if you can see the cursor, but you can see that at the beginning of this graph, the prevalence of ICAS is much higher in African-American, non-Hispanic, or Hispanics compared to non-Hispanic whites. And then as the population ages towards age 60, then those curves converge, which is worrisome, because that means that most likely people who have ICAS when they're younger, they have a higher mortality risk, and therefore they don't get to make it to the 60s or 70s. And the people of these ethnic groups who get it to the 60s, 70s somehow are survivors compared to non-Hispanic whites. And even if you stratify by all vascular risk factors, there's still a persistent disparity in the odds of having asymptomatic ICAS in the community here in Northern Manhattan. So moving into risk factors, you probably know this and you see it every time, but the age, we can't do anything about it. It definitely comes with age. But the things that we can do something about is blood pressure, so controlling hypertension, dyslipidemia, and diabetes have been consistently associated with a higher prevalence of ICAS, and decreased physical activity from a subgroup analysis in the SAMPRI that I will talk to. I would talk about in a few more minutes. But these are actionable things, so you can definitely do something about it. And I don't know if it's your experience, but in my experience, more often than not, the targets to control these risk factors have not been met. Now, talking about ICAS versus ICAS. So ICAS stands for stenosis, intracranial arterial stenosis, and ICAD with a D is intracranial atherosclerotic disease. So when we talk about atherosclerosis, what do we mean? So what we mean is growth. And that is because in a pathological cut, cholesterol deposition looks like gruel, looks white in stains, and it's because the cholesterol crystals are devoid of collagen, and so these colors do not bind cholesterol, therefore the slide appears white. Now, even from a pathological perspective, you often see autopsy reports that speak of athero, but that may be a misnomer too, and there's an error. There's a possibility of misclassification. Why? Because I'm showing you this example of circle of Willis here, and actually let me bring the laser point. Maybe you see it better. There you go. So you see here that this basilar is evidently damaged. You see these little white dots here, and pathologists especially, assume this is athero. But I've shown them examples that if you actually look at it, you cut it out, there's no athero underlying that area as a whitish spot, because the changes in collagen change the appearance of the vessel, but it's not necessarily atherosclerotic mediated or cholesterol mediated. And it is very time consuming to cut the vessels and stain them. And that's why most pathologists don't do it. But when you see athero, just take it with a grain of salt and try to really understand whether the cholesterol was seen or not, or whether it makes sense in a clinical context that someone may have athero or not. Again, this is just intima fibrosis, but there's no cholesterol clefts being deposited in this area. Now, in real life, we don't do pathology. You don't do pathology when you see people on the wards with a stroke. And so we have to talk about ICAS or stenosis. Now, ICAS is a much broader term and it's purely descriptive. And I prefer that actually. In radiology reports, I prefer to see there's evidence of high degree intracranial stenosis as opposed to there's evidence of, intracranial athero, because I don't think we really know what we're dealing with. But it's an example of almost a flow gap here in the angiogram. And I just want to bring your attention to differentials of causes of stenosis that have nothing to do with athero. And so that includes infectious vasculopathies, moya, heel dissections. I'm going to show you an example of a heel dissection that impinges into the lumen clearly and is not atherosclerotic. Another cause that I often talk to trainees at Columbia is partially recanalized thrombus. So in people with AFib, if you have pristine circle of Willis, there's no stenosis anywhere, and suddenly you see high degree stenosis in a single area, sometimes distally, like in the proximal M2 or distal M2 or A2, I would be skeptical of calling that athero. Why? Because athero is not a focal disease. Usually you see the vessels that look diseased, and you may see an area that is has high degree stenosis, but it's not just suddenly like that. It's most likely diffuse, and we have pathological evidence to prove that. So do not forget that AFib, if a clot goes into the brain and breaks up partially, can become incorporated into the wall and allows for blood going through. Therefore, patients may not have a stroke, but they have like an isolated stenosis. And there's the phenotype that is closer to my heart that I'm trying to advance and distinguish from athero, which is non-atherosclerotic aging. And these are examples of what that looks, which is mostly intima thickening that is concentric, is throughout the vessel, and is mostly the reflection of flow through decades of life. Certainly risk factors play a role in accelerating that degree of intima thickening, but as I show you in the slides before, there's no cholesterol here, it's just intima fibrosis. And if you plot the evidence of pathology-based athero against the degree of stenosis, evidently phenotypes that have athero do have stenosis, but also there's stenosis that is caused by phenotypes in which cholesterol does not play a role. It's mostly intima thickening, and it's mostly concentric, as I've shown you. And if you were to say, well, who has a phenotype that is mostly atherosclerotic, how do we know that? Well, in people 60 or older, or even 80 or older, you see that people can be all over the place. So, and this is not from a hospital-based study, it's for an autopsy study that is perhaps less biased because the people who went into this study donated their brains while they were living. So it's not necessarily that they went to the morgue and from the morgue to my study. And so you see that older people can be all over the place. There's going to be someone that has a predominantly atherosclerotic phenotype in which cholesterol is the major driver of that pathology. But there's other people who are going to have vessels that look diseased, degenerated. There's maybe intima thickening, it may be dilated, but there won't be atherosclerosis. And how can we get into that degree of certainty with pathology? Well, I'm a little skeptical overall, but I think this is certainly something that can be used, which is high resolution wall imaging. And I don't know if you guys do there in your hospital. We do it for research protocols here at Columbia, but clinically, we often have a hard time getting it done because of the typical constraints of time, magnet, and radiologists not feeling comfortable having images that are not that familiar with in the DICOM paths. So, but in these examples, you see how you could look at the arterial wall and you could try to make inferences as of whether the degree of intima thickening is concentric and eccentric. I think that is perhaps one of the most promising features of high resolution wall imaging that we could potentially use. eccentric intimate thickening being mostly associated with atherosclerosis, whereas concentric intimate thickening not, as I showed you before. If the vessel were to enhance and it's concentric intimate thickening, you think of, vasculitis or other causes that are not mediated by athero. But this remains, somehow experimental. It has not been validated in any specific trial. And the disadvantage is also that the signal to noise ratio is such that that's the source of my skepticism, that sometimes it's just very hard to distinguish, because the minimum resolution that you can get before you lose a lot of quality is 0.5 millimeters or 500 microns. And may I remind you that the thickness of the wall is about 200 microns to 50. So you're scanning at a minimum unit of accuracy that is double the size of the wall that you're trying to look. So there's a lot of inference here. And people who do this are very enthusiastic about it, and they present papers with the best possible examples. I can tell you that is not always as good. It's actually very hard to get good quality imaging that you can say, well, I think I buy this. But we'll see where the field goes. I think as newer MRIs come through, we do have a grant that is, we're going to collect 600 images using high resolution arterial imaging on a 7T scanner. So we'll see if that perhaps increases or decreases the signal to noise ratio. So what happens to people with asymptomatic intracranial stenosis? Well, in the Northern Manhattan study, again, we saw them between 2003 and 2008. Since then, people have been followed on a yearly basis, an ongoing annual telephone surveys. They also have event adjudication. If someone reports that they've had a stroke, we treat about 80% of the Northern Manhattan participants at our hospital, so we can easily do adjudication. And in the other 20%, we try to get records from other hospitals. And so what we found, so again, the 66% are Hispanic, 61% are women. The mean age at the time of MRI was 71 plus minus 9 years, and 40% had any degree of stenosis, and the majority in the anterior circulation. So what happens is that people with high degree stenosis will die more. And the risk is not negligible, actually comes up to about 5% per year, which you may say, well, it's not that high, but let me just put it in perspective. People with a lacunar stroke that come to your hospital, the risk of death is no more than 2% per year. So this is an asymptomatic phenotype, okay? They are not in the hospital, they're walking on the street. And because of the prevalence of ICAD, they have a 5% risk of death in per year. So it's actually pretty high. And of vascular events, in the following 10 years, these people, 40% will have a vascular event, which is defined as a stroke, MI, or any combination of the other cardiac outcomes that we look into. And so the risk is persistent when you adjust for competing risk of death and when you adjust for the disparities in risk factors. So in addition to knowing that hypertension evidently plays a role, there's still knowledge by getting this phenotype and understanding it better. So what about atherogenesis? So what is the underlying process that leads to athero? Well, it is complex, but the key role to this is oxidized LDL. So again, athero is a cholesterol-mediated phenotype, and see the LDL coming into the wall, eventually swollen out by macrophages, which then turn into foam cells. Foam cells are reversible, so kids have it when they're born in the aorta. And they are reversible, they come in and out, but there's a point of no return in which foam cells start dying. And so once they start dying and undergo apoptosis, the necrosis is what creates a very intense inflammatory response, which eventually leads to the atheroma formation, which is the coalescent formation of cholesterol into the arterial wall, which gives the appearance of growth that I've shown you before. Because of these possible pathways to intervene in multiple spots, the newer therapies that are coming down the pipeline have to do with inflammation. And in fact, I don't know if you're familiar with a study that looked at the effect of colchicine in MI. And they published it in a New England Journal of Medicine, and they found that there was a decreased risk of MI among survivors of MI when they were taking colchicine compared to standard of care. And there are now 2 other trials looking into colchicine in stroke. One, I think, actually 3. I believe 2 are in Australia, 1 in Canada. And the one in Australia has a pre-planned analysis to look at ICAT. So I think we're going to learn about it. But this is, in my opinion, the future to, in addition to statins and aggressive medical therapy, try to do something more to decrease the risk of a stroke. Another point that I like to drive, and I'm sure that you've all seen radiology reports calling intracranial calcifications as atherosclerosis. I don't think that's necessarily correct. And again, one of our residents here, Stephen Shapiro at Columbia, looked at our specimens, and we classified pathology-based classification as scatter, as you see here, so very little dots in the wall, barely seen, and then coalescent, in which there was like a big chunk of calcium that most likely will show up on an MRI imaging, or sorry, a CAT scan imaging. We plotted this against age, and you clearly see that they both phenotypes rise with age. Some people have a scatter and coalescent, and they run in parallel with athero. But when you do actual models, the association with, this is just an example again of one of our patients who had a brain CT scan pre-mortem, died shortly after, and we were able to get the vessels. And you can see that the vertebral artery that is calcified here, you can see here calcium, but there's no actual cholesterol deposition, whereas in hyperdense vessels that we sometimes see in the MCA, for example, there was scatter calcification. But what is more remarkable is that there was atherosclerosis here with these atheromas forming on both sides of the MCA. So bone calcification in the vessel has to do more with bone marrow than with atherosclerosis. And again, this same example that I showed you from the vertebral artery, there's actual bone marrow formation here. Hematopoiesis. Now, I didn't make that diagnosis. I asked one of my pathology colleagues to confirm, and they confirmed this is actually bone marrow and hematopoiesis in the vessel in the brain. So calcification is not synonymous of atherosclerosis. They do coincide because they both happen with aging, and in fact, oxidized LDL can trigger necrosis, which then in certain people can lead to calcification, but it's not the only source of calcium. So other injuries such as smooth muscle cell dysfunction can lead to bone formation, especially in people with CKD that have abnormal calcium metabolism. So although I'm sure radiology will continue doing that, you take it with a grain of salt. And when you see calcification, take it as a phenotype of aging, but it's not necessarily synonymous with atherosclerosis. In terms of the genetic underpin of ICAT versus dolichoectasia, and here I'm using dolichoectasia synonymous of non-atherosclerotic aging, but basically dolichoectasia is defined as a dilated vessel that is tortuous, and people have historically assumed that is a form of athero, but I have shown in multiple other studies that it's not. And I am not going to focus on this anymore because I think there's sufficient information out there to no longer consider this the same phenotype. But just for the sake of discussion, we looked at the genes with one of my postdocs at Columbia, Minghua Liu. She reviewed the literature, identified all the reported SNPs that have been associated with intracranial atherosclerosis, and we looked at whether they have been described in people with dolichoectasia. There was no overlap at all between these genetic biomarkers. In the Northern Manhattan study, we only found 2 SNPs of all those reported before that were present, one that was protective against ICAT or intracranial stenosis, and the other one that was deleterious. but the actual prevalence of this genetic SNPs is so low that it actually has not a lot to do with the actual prevalence of the disease, which suggests to me that genetics is not a major driver of ICAD, as it is uncontrolled vascular risk factors in certain populations. So it's very difficult to disentangle. And I believe it's actually dangerous to think that the disparities in ICAD that you see in the hospital have to do with genetics, because that, you know, creates a passive mindset. You can't do anything about genetics so far, and so let's just move on with it as if nothing had happened. But the reality is that what you can do about is focus on control of diabetes, hypertension, dyslipidemia, which more often than not are wildly uncontrolled. And again, that's my experience of the people that I see at Columbia. I don't know if your patient population is similar. In terms of, again, definitions are important. This is the traditional view of the American Heart Association recommendation to classify arterial disease. I don't think it's fair. And the reason for that is that there's a big chunk of phenotypes, all this pathological intimate thickening, erosion, healing, thrombosis that can happen without athero. So athero should be circumscribed exclusively to atheroma, cholesterol-mediated disease, and not to anything that looks wrong in the vessel, which is the tendency of some pathologists to look into. And I'm telling you why it's important. So in the coronary arteries, there's a thought that they can withstand intimate thickening early on by compensating outward, meaning there's intimate thickening, the vessel dilates, and the lumen is preserved. But in the brain, we found no such compensatory outward remodeling. We found that with any extent of intimate thickening, the lumen is going to get reduced. So there's very little compensation. And we did statistical models to test that hypothesis, and we could not confirm that there was outward remodeling as a compensation of intracranial stenosis. And so that makes it a very different pathology from what typically has been described in the coronary arteries. So how does ICAD causes stroke? So the main thing is plaque rupture. You can see here that this plaque is highly inflamed, surrounded by macrophages. There's the cholesterol crystals. There's a thick area between the plaque and the lumen, so that is good. That's protective against rupture. But you can have a highly inflamed endothelium, even in plaques that are not very stenotic. So you can see this vessel, the lumen is pretty wide. And most likely, if you were to do a CTA or an MRI, you wouldn't see this degree of stenosis. It's very minimal, it's no more than 10%. But nonetheless, it's a highly inflamed endothelium. There's very active tissue remodeling here, as you can see with this stains of metalloproteinases. So what does that mean? Well, you can have endothelial erosions. Endothelial erosions can be the source of thrombosis. And so in people that have ESAs that you don't really know what's causing it, you eventually don't find AFib. And, you know, we'll see what Arcadia shows. But there's a chance that their endothelium may be substenotic, but nonetheless very inflamed. And that could certainly be a trigger of thrombosis. How do we know that? Well, I think we need to move into biomarkers of this hard endothelium and test whether doing something different than aspirin would help decrease the risk of thrombosis. But I'm going to show you an example of a plaque rupture. You clearly see here how there's a fracture in the plaque. Blood eventually leaks into the atheroma, which has highly thrombogenic materials. And that is what causes thrombosis. So that thrombus can have three fates. Either it ruptures, and we have evidence from the Myriad study, which is an observational study, that in people that have so they had to have ICAS of 50 to 99% to be enrolled, and they found that 25% had a second stroke within 51 days on average. And one of the predictors for a high risk of stroke was actually the number of DWI lesions. And that implies that that plaque was probably unstable and people kept having either multiple little strokes. So there was a clot that broke off and eventually migrated. But this is just to show you epidemiological evidence. The plaque rupture can be inferred in people with ICAS and multifocal DWI lesions, and those patients are at a very high risk of recurrence. Now, ICAS can also cause hemodynamic injury. We tend to speak of it as a border zone infarction or internal MCA border zone. Some people use watershed, but we don't really use that term anymore, especially I know people who know Dr. Moore at Columbia, he's very against that term. And I guess that transpired into me. So border zone is the way that we refer to these lesions at Columbia. And one of our former fellows, Shadi Yagi, looked into this, and what he found was that the longer the Tmax, or the longer it takes for the blood to go into the brain, if there was a mismatch between the core volume and the perfusion, the risk of having neurological deterioration was much, much higher. And the risk was attenuated with flow that was able to go through with a Tmax of more than 4 seconds. And again, just to show that the high degree stenosis can impact flow, and with it impact the chances of having neurological deterioration. In the Sampras study, they also looked at collaterals and found that people with poorer collaterals had a higher risk of recurrent events or poorer outcomes. And again, has to do with flow and hemodynamic injury. And David Libeskind also looked into that and presented this data. And in people with a Tmax delay on perfusion, the risk of border zone infarct was significantly higher. In the Veritas study that is focused on high degree posterior circulation stenosis, they also found that the blood flow was a predictor of recurrence. So people with low distal flow status had a much higher risk of recurrence in 24 at 2-year mark. So up to 35% had a second stroke within 2 years if you had this low distal flow status, so very high risk. And the third mechanism by which ICAD or intracranial atherosclerosis or stenosis can cause a stroke is branch occlusive disease. And again, I think we underestimate this in the Western world. It's very often mentioned in Asia, in studies from Asia. But this is a pathological example that I don't think you require a lot of imagination to think of that tiny vessel coming out of the large vessel being embedded by intima thickening. It's very easy to occlude this vessel, and that would eventually lead to stroke if it were to be occluded. So how do you think that we will see these in a CT or an MRI? I don't know, maybe just minimal luminal irregularities, but I invite you to look at it in your lacunar strokes that we usually call small vessel disease. I think a significant proportion of them are actually not true small vessel disease. They manifest radiographically and clinically as such. They're most likely branch occlusive disease. Dr. Kaplan calls this branch atheromatous disease, but by now you can understand that I'm skeptical about the athero part of it, because again, traditionally, intima thickening has always been thought to be atherosclerotic, but I don't think so. And therefore, I prefer to use branch occlusive disease, but we both are talking about the same thing. It's just a matter of terms. In the bars, in the brain arterial modeling study that we've looked into what's happening in the penetrating vessels that come off from the large vessel and the large parent vessel. And at any circumstances, whatever's happening at any extent of disease, what's happening in the large vessels also happening in the small vessel. And I think it's important to understand this, because I don't think small vessel disease is a thing on its own. It's just that the technology that we have, we cannot see whether the parent vessel is diseased. And as you see the dimensions of the lumen of small vessels, it takes very little burden of disease to actually occlude a small vessel. Whereas a large vessel, you require more volume of a plaque to actually cause something. So I think that the distinction is, it's important for therapies up to a certain point, but I think they both represent the same continuum of intracranial arterial disease that is generalized into the brain and that may manifest at different points in the lifetime of a person as either small vessel disease, so-called, or large artery stenosis. Something else that I like to point out is that ICAD is dynamic, so sometimes the plaques regress, and statins certainly help, but not only. And that's because plaques can have intra-plaque hemorrhage, which eventually gets healed, and that causes retraction of the clot, and that could potentially lead to changes in the way that we define stenosis. Now, it's important to look at the methods used to define stenosis, because if it's just MRA or CTA, it's too noisy to really quantify as a 7.5% regression. I would say angiogram is perhaps the most important one, but we don't do angios as much anymore with CTA. So in terms of risk of having events, if you have ICAD and you have a stroke, your risk of a stroke is much higher, up to 8%. If your degree of stenosis is 70% and you've had a stroke, you have up to 23% risk of having another stroke. That is incredibly high. And going into what to do, I think for trainees, and this is the most common thing that you're going to discuss on RAM. So the landmark trials that inform us what to do. The WARS trial led by Dr. Moore, Columbia, looked at whether warfarin was better than aspirin to prevent any type of a stroke in people with no AFib, all comers except AFib. And what they found was that it was actually warfarin did prevent ischemic events, but you pay the price in bleeding. And when you put them together, you combine the risk of ischemic stroke plus the risk of bleeding, aspirin was better. It did prevent ischemic events, but you do not pay the price in bleeding. So since then, we use aspirin to prevent stroke in general. Was it specifically targeted people with intracranial stenosis at 50% or greater? And they tested warfarin against aspirin, and similarly, warfarin was actually better at preventing ischemic stroke, but because people bled more, aspirin turned out to be the best option. But it's important to keep this in mind. So there is this data from WASIT that warfarin did help to prevent ischemic stroke. So some people who may have to have warfarin anyways, let's say for AFib or other valvulopathy, if they do have ICAD, I don't think you have to add an aspirin, for example. Why? Because we have this data and they already have to be on warfarin. So it's not that you can change the risk of bleeding. And so it's important to remember this data. The surgical interventions for ICAD are no longer used, only rarely, especially the bypass, direct bypass. There's data these days, and I don't know if your neurosurgical colleagues do it at downstate, but that indirect bypass could be an option. The data is pretty random, meaning it's probably biased by the people who go into the study and the outcomes. We don't have a trial that has looked into that. I think Nestor Gonzalez at Cedars-Sinai in California is closer to a more formal study of EDAS. To basically open up the skull and putting a vessel against the skull to let it form angiogenesis branches. Going into stenting, stenting is no longer used as a standard of care. It's not standard of care under any circumstances for ICAD. We rarely use it under humanitarian exemption from the FDA in people that have had at least 2 strokes that we have nothing else to offer, presumably risk factor well control. And in those settings, I think I remember maybe 2 or 3 cases in 10 years that I've seen at Columbia being done in this setting. We rarely do it. And this is because for the cumulative data that has shown that stenting in ICAD is associated with a higher risk of death and a higher risk of a stroke. It all started with registries as usual. And in registries, you see that even then there was a 30-day risk of a stroke of 6.6%, but there was no comparison arm. Then there was the wingspan stent registry, again, that showed that the rate of recurrent stroke was 14% in people with high degree stenosis. And finally, I'm going to skip to Sampras for the sake of time. Sampras tested whether aggressive medical therapy versus stenting was different or better at treating people with high degree intracranial stenosis. Both arms underwent aggressive medical therapy because the interventional arm had to be put on DAPT using clopidogrel and aspirin for 90 days. Then the medical arm used the same recipe. Okay, so when you hear about Sampras showing evidence that DAPT was superior to aspirin, or that the use of DAPT in the setting of intracranial stenosis based on Sampras did not test that hypothesis. It was an arrangement because they want to equalize the arms. Or we do have data on DAPT from other studies, but it's not Sampras that demonstrated that DAPT was superior to other therapies. And it's important just to remember that. It's important to also understand that aggressive medical therapy in Sampras has nothing to do with what we actually have in real life. Like I've never had a life coach call my patients and see if they are taking their medications and see if they're exercising, they're eating healthy, they've stopped smoking. It never happens, but it did happen in the trial. So it was the ideal definition of aggressive medical therapy. And so the primary endpoints, were stroke and death within 30 days, and ischemic stroke in the qualifying artery beyond 30 days. And what we found was that the risk of events was significantly higher among people with the stenting, almost double compared to people with aggressive medical therapy alone. And most of the strokes happen early on with the stenting. Here you see that the curves never actually met, meaning you pay up in a very initially a very high risk of events related to the procedure itself. And it never actually came down to the point in which the curves would have crossed, because you could have said maybe you pay the price early on, but the people who actually don't have a stroke do better in long term. There's no evidence of that. And there's just a recent Chinese study published a few months ago. I'm blanking on the name, but it looked at a stenting beyond 30 days with the idea that maybe if you do stenting acutely, the plaque is fresh, the clot is fresh, and you're breaking in. And this other study looked at rolling after 30 days, and there was no benefit of stenting in ICAT. So again, this was confirmed. The results are widely known. And because there's a gap in therapy, there's a new study coming from Brian Ho in Florida, and also Dr. Chimowitz, who was the PI of Sampras and WASID, looking at medical therapy for ICAT. So this study, the rationale for it is that ICAT is an awful disease. Okay, I'm going to take you to this table. You can see the risk of a stroke associated with multiple things that you see on surface. These are some of the most common causes of a stroke. Look at how they tally against ICAT, more than 70%. None of them are close to that. So it is probably one of the worst possible things that we deal with as a stroke neurologist. It has one of the worst outcomes. And even in Sampras with aggressive medical therapy, the 1 year risk of events was almost 20%. And so there is a moral imperative to test different therapies to try to bring down that risk. And the standard of care in CAPTIVA is defined based on a survey that to use neurologists, in which the overwhelming majority said that their standard of care was to use dual antiplatelets and aggressive medical therapy to treat people with ICAT. The definition of DAPT was aspirin and Plavix up to 90 days. And that's what the HA guidelines for secondary stroke prevention recommend, up to 90 days. It is not 90 days because we don't really know if it's maybe a month is enough or 2 months are enough. We don't really know. And so it's up to the provider to decide the length of it. Usually we don't go beyond 90 days, but CAPTIVA will go beyond 90 days. So basically CAPTIVA is testing clopidogrel plus aspirin for 1 year, and that's going to be the standard of care. The arms to be compared against the standard of care is ticagrelor twice a day plus aspirin, based on the Dales and Prince trial. And the other arm is low dose rivaroxaban and aspirin. So COMPASS and Commander trials in the cardiac literature are supporting that. Important to remember that we are not going to compare ticagrelor plus aspirin against rivaroxaban and aspirin. These are going to be compared against the standard of care. So there's a possibility that one of the arms fails the safety or efficacy interim analysis. It may be terminated, but the other arm may continue. Okay, and even at the end, if we complete the results, we won't be able to say whether these two are equivalent because they're going to be compared against the standard of care. Another novelty is that the first interim analysis is going to be done when there's 450 people enrolled, and that is to look for safety. If there is a safety boundary that has been crossed, then the trial is going to be stopped, especially if it's futile. If it's same for the rivaroxaban arm, if they pass that initial safety screen, the next one is going to be efficacy, and if they are safe but futile, they're going to be terminated. Same for the rivaroxaban arm. If one of them passes, they will continue against the standard of care. The other arm may be terminated. And there's also a planned subgroup analysis in the standard of care group to look at whether they have CYP2 C19 loss of function carrier, which has to do with Plavix activation. The idea is that there's equipoise and point subgroup analysis from the point trial. There was no difference by the genotype in the efficacy of aspirin and Plavix or clopidogrel to reduce the risk of stroke in this population from the point trial. But CHANCE-2 in China did show that people that had the loss of function carrier actually did better with ticagrelor. So I think that the CAPTIVA trial is trying to also take advantage of the recruitment to test this hypothesis. So the take-home messages are that athero is an awful disease and it's one of the most important causes of stroke in the world. In China and Korea and Japan, it's up to 40% of all the strokes are caused by intracranial stenosis. If you look at the population, a general population sample from those countries, it's not that different from what's happening in the US in certain ethnic communities. So it's very important to study it. It's not unique to a geographic region. I'm sure that you see them on rounds often. And the ethnic disparities have to do more with risk factors than with genetics, as I've shown you before. Lumen-based stenosis, which is what you see on rounds, is not equal to athero, but in a context, in a clinical context, someone with diabetes, high LDL, hypertension, smoking, etc., chances are you're dealing with athero, especially if the vessels around it and throughout the brain look diseased. Asymptomatic intracranial stenosis is not something that you will see in the hospital for the most part, but we see it in the community. It's important and it does carry a risk of events. We don't know what to do with it yet, but hopefully we will based on this data. So hemodynamic injury and multi-infarct pattern in people with a stroke carry a higher risk of events among people with ICAS. And with that, I'd like to finish and leave some time for questions, or you can reach out to me as well to my email at Columbia if you have questions or the issues that come up. And thank you all for your time.
Very good talk, Jose. I have a quick question for you regarding the risk factors. In Brooklyn, we have most of our patients have intracranial atherosclerosis, as opposed to Northern Manhattan study where you have some carotid stenosis, which is much more prevalent in Manhattan. How do you explain that? Is there an explanation for this? We have very rare carotid stenosis here.
Well, what's the ethnic composition of your population?
So we have the vast majority is of Caribbean origin. Okay. African American.
Yeah. So, you know, hypertension is a big deal in these communities. When I was in Miami, I remember looking at Black Caribbeans, which were mostly Haitians, and the prevalence of uncontrolled hypertension was rampant. It was just an incredible amount of uncontrolled hypertension. And so, alluding to that, in Manhattan, so in Northern Manhattan, we do have ICAD, okay? But it's mostly in people that have uncontrolled risk factors. Now, cervical stenosis and the fact that is thought to be more of wider individuals is probably, it has to do with when the risk factors started. So in my opinion, ICAD is a terminal disease. I mean, the risk is so high of having an event compared to cervical stenosis that you must have a lot of disease burden in order to get ICAD, whereas cervical stenosis, you know, you can have it earlier on, and it's mostly, in my opinion and in my experience, strongly associated with smoking, as opposed to diabetes, for example. Diabetes has a predilection towards intracranial stenosis. So I think it's a combination of risk factors. There is really no data supporting the idea that it is due to genetics. And the Oxfam study in the UK, I think, has dispelled a little bit the notion that ICAD is just a disease of ethnic minorities, because the majority of people in the Oxfam study, these are people who had a stroke, came to the hospital, did an MRI, and they had an incidental, unrelated ICAD in another vascular territory. And the prevalence of ICAD in white English participants was almost as high as in non-white English participants. So I think that it's a matter of perspective, and it's a matter of how deeply we look into that. But we do have cervical and ICAD here in our hospital. It's not just cervical.
The second question I have regarding imaging, I understand there's some criteria that help us distinguish vasculitis versus atherosclerosis, intracranial atherosclerosis. Do you apply those criteria, or what do you think? How valid are they?
Yeah, so, you know, again, I'm very skeptical, really, but people say that if you have eccentric intimate thickening, most likely you're dealing with athero. And I up to there, I think I agree. The contrast enhancement of the vessel, I mean, I see it so often. You know, we just had a patient last week that had like recurrent vascular strokes, and we did an MRI with and without. The vessels, all his vessels kind of pick up contrast a little bit, but it's probably because the contrast somehow, you know, travels to the areas of lower flow. So you think of the flow in the vessel, the middle of the vessel is going to have faster flow, and as you go into the sides of the vessel, it's going to be slower. So I don't think it's true wall enhancement. I'm sure that with better technology, more resolution, you can see some enhancement. Like if you were to see a person with no vascular risk factors, okay, who has concentric intimate thickening, has a stroke related to that area of intimate thickening, and that area enhances, and the rest of the vessels don't enhance, like I think you could convince me that that is inflammatory and not atherosclerotic. But the problem again is that radiologists who do this, they tend to abuse in what they see. And you often see, no, we saw an atheroma and we quantified it. Like they use all these pathological definitions. When you look at the images, like I just don't buy it. And I may be biased because I do look at pathology a lot and I'm spoiled by that rich of details. But I don't know, I think really more formal data. You mentioned a keyword which is validated. Rarely these phenotypes have been validated against pathology, and if they have, it's like in a very few cases. So I think more needs to be done to, you know, advance this field with definitions that are just appropriate and not beyond speculative of what you're actually seeing.
Thank you very much.
Welcome.
There's some questions in the chat. Dr. Stephen Levine asks, when should one screen for Fabry's in patients with dolichoectatic vertebrobasilar disease? Is it routinely?
Yeah, so we don't do it routinely, but it's interesting that you mentioned, because we have published a study in which we looked at not necessarily Fabry's, just lysosomal enzyme activity, right? So we had a sample of about 120 patients who came in through a Parkinson's study. Some of them have Parkinson's, some of them did not. They had genetic sequencing for genes related to the 5 common lysosomal disorders. They also had measured their lysosomal enzymes. And we excluded people with definition of Fabry's or Pompe's disease and focus only in people without these diseases, but who also had lysosomal enzymes measured. And what we found is that even in people without Fabry's or Pompe's, those that have more dilated brain vessels had a lower enzymatic activity, suggesting that there's some sort of lysosomal dysfunction that is not genotypically considered a disease that may play a role in arterial remodeling. So we are currently collecting data in a cohort that we're bringing back, the NOMAS cohort we're bringing back for MRIs in about 300. And so we're doing dry blood spots and measuring to measure lysosomal enzyme to look more into this, because one idea is that, you know, we have enzyme replacements, and what if in people with hugely dilated vessels, they do have lysosomal dysfunction related to these enzymes, and see whether perhaps we should explore treating them. But when do I test for Fabry's? I guess in people who have nothing else, and if they tend to be a little younger, like in their 40s, but otherwise, I would not necessarily test for it.
What about cigarettes as a risk factor for intracranial atherosclerotic disease?
So cigarettes are a risk factor for pretty much any form of disease. So it could be intracranial athero, but it can also be dolichoectasia. The cigarettes activate metalloproteinases, and metalloproteinases cleave, as I show you in some of the examples, they remodel the tissue and usually cleave elastin, and elastin is the protein that allows for a recall of the vessel, so they start turning rigid, which then eventually can dilate. So would you, I mean, I don't think it really matters, because you would still recommend abstaining from smoking, right? Regardless of you have ICAD or any phenotype, you should quit smoking. So you can go either way in terms of phenotype, but I don't think clinically it matters, because it doesn't change the treatment per se.
And we have a final question in the chat. Any treatments shown to be promising to reduce intimal thickness in humans?
Not that I know, and that's an interesting question, because I said what to do with a vessel that is already thickened. I don't think you can target endothelial cells just to get apoptotic. I don't know. I haven't seen anything like that. My hope is that what we could do is try to modulate the protein content of those vessels. So preserving elastin or regenerating elastin, I think, in my opinion, has more promise, as opposed to have endothelial cells regress. The reason being that if you have a vessel that is thicker, but it does have a lot of elastin, you know, the vessel is going to recover some recall, and you're going to decrease arterial stiffness with it. And I think part of what we see specifically regarding neurodegeneration in ICAD has to do a lot with stiffness. So you were to, you know, stop the progression of endothelial thickening, and, you know, enriching with elastin that vessel so that it becomes less rigid. I think that would be fantastic. And I think that that may be more realistic than endothelial regression.
Thank you, Dr. Gutierrez. I had a question. So you spoke about the CCR5 inhibitors being used as a possibly being used in atherosclerosis. It's interesting that they're also used in HIV patients. So is there any data to show that in HIV patients who take these medications, there's the progression of intracranial athero slower?
No, with Marabinoc, but speaking of HIV, abacavir is very well known to increase the risk of vascular events. So if you were to see a person with HIV and ICAD, look at the antiretrovirals, and if they are on abacavir, talk to their ID doctor and ask whether they can be switched to something that does not have abacavir. In the other drugs, as you know, HIV on its own is a whole different topic that has to do a lot with TNF alpha. So, you know, whether decrease in viral replication but persistent TNF-alpha expression is actually a situation in HIV that predisposes to arterial disease. I think something that we're actually exploring as well in that other study I told you we just recently got funded to do 600 high-resolution wall MRIs. Well, half of them have HIV, half of them don't. The idea is to look at the inflammatory markers and see whether a pro-TNF environment could actually predispose to some of these phenotypes. And it's important, you know, that you mentioned the antiretrovirals, because we will certainly classify them and see whether they have any association with a differential inflammatory profile in people with HIV. Stay tuned for you come to our fellowship.
Thank you. And one final question. So since intracranial atherosclerosis carries such an overwhelmingly high risk of stroke, are there any imaging techniques to identify vulnerable plaques? And if we're able to do that, does that make the case for primary prevention using dual antiplatelet?
I presume you talk about asymptomatic ICAT.
Yes.
Because in people with symptomatic ICAT, you do use DAPT. I don't know what the answer to that is. I don't think so. I wouldn't do it because DAPT does come with the risk of bleeding, and certainly the risk of a stroke when I gave you the numbers of the risk of death is 5%, 6% per year. That is of all vascular events. The actual risk of a stroke is much lower, it's closer to 2%. And the reason for that is that that plaque may be stenotic, but it does have a different risk profile than plaques that end up breaking. And in order to do such study, you will need to screen a lot of people, right? Because we're talking that from the general population, 8% have 50% or greater. The prevalence of 70% or greater is 5%. So how many people do you have to scan in the community to get to a good number of 70% or greater, and then test whether high-resolution wall imaging would identify features that can discriminate who should have aggressive therapy, even if they are asymptomatic. So I think that would require a humongous number of studies. But one of my ideas that I just haven't had a lot of time to pursue is to create a score to try to, you know, target or screen high-risk individuals. So, and we have looked at a preliminary score, and it was very hard to predict who had high-degree stenosis because the risk factors are so prevalent in OMAS and in our community that it's just hard to use them as a tool. So there may be a value perhaps looking into inflammation and see whether inflammation could also help us identify phenotypes that have a higher risk.
Thank you so much. I think we're well over time. So thank you for joining us today. It was a very wonderful lecture, and I think it's especially helpful for residents. So thank you for joining us.
Thank you for inviting me, and hope you have a great day today.
You too. Thank you.